So we'll make a formal start. Welcome this morning to our webinar being presented by Continence Victoria, and the topic's Carers Count Support for Continence Management. I'm Andrea Salmon. I work with MS in Victoria and I coordinate the education programs, and today I will be facilitating this webinar. And I'd like to introduce you first to Amy Simmons from Continence Victoria. Thanks, Amy.
Thank you, Andrea. Thanks for joining in today. My name is Amy. I'm a Health Promotion Officer at the Continence Foundation of Australia Victoria branch. I have with me today my manager, who is the Executive Officer of the Victorian Continence Resource Centre, Lisa Ragg. This is actually our first webinar that we have ever participated in, so we hope that it all runs smoothly, and we are really looking forward to spending the next hour or so with you today to having a chat with you about carers count support for continence management. So firstly, I'd just like to talk with you a little bit about who we are and what we do. We are the national peak body for bladder and bowel health. We are a not-for-profit organisation, and we are funded by the Department of the Social Services at a national level, and we also receive some state-based funding from HAC, Home and Community Care. Our vision is to have a community free of stigma and restrictions of incontinence. We promote continence awareness, and how we do that is through education on treatment and management options throughout the community. So we go to a lot of community groups and run sessions. We also train health professionals, and we help people access the right information and support services, as well as develop resources. One of the services that we do offer is a national continence helpline. It's a free call, 1800 33 0066. It's open Monday to Friday, 8 AM to 8 PM, and is staffed by a team of continence nurses, and they can provide advice over the phone. They can also recommend certain products. They can ask questions around eligibility for funding for products. They're a fantastic resource. They're a national service. Also, at a state-based Victorian level, we have the Victorian Continence Resource Centre Advisory Service, and that number is 1300 220 871. And there are continence nurses and a pelvic floor physiotherapist that can also offer advice via the telephone. So when we talk about incontinence, it's quite a broad term, and it means the accidental or involuntary loss of urine or bowel motion. So we basically don't want urine or bowel motions or leaking of urine when we haven't reached the toilet. That is what we don't want to happen. We want people to have control over their bladder and bowel and go to the toilet at the right time in the right place when they wish to. Any leakage is no good, no matter how little or how much, and it's really important that if it is occurring, that the right help is sought and the right management and treatment options as well. So, caring for yourself. Carers need support. So carers who usually assist with managing bladder or bowel control report greater changes in their physical or emotional well-being, weariness and lacking energy, or worry or depression due to their caring role, compared with carers who do not assist with managing another person's incontinence. 10% of all primary carers manage another person's incontinence. And we know that carers need practical support, respite and training. And it's also important that carers look after their own health, including their own bladder and own bowel. And carers are also prone to incontinence issue due to heavy lifting or poor health. So it is important for the carers themselves to seek professional help sooner rather than later. Each year we recognise World Continence Week, and last week was World Continence Week 2015, and each year the National Continence Foundation of Australia have a theme, and this year's theme was Carers, which aims to raise awareness about incontinence-related issues. And the theme was Tell Someone Who Cares. And as part of the World Continence Week, a new web page was launched, Caring for Someone with Incontinence. And you can see a screenshot of the web page on your screen, and it has a lot of practical information and advice on where to get help.
Did we want to poll people about whether they are caring for someone?
Yes. Yes.
Is that now, or is that coming up later? Have I jumped the gun?
Oh no, that's okay. Now would be good. Yeah, thank you, Andrea. We're just going to run a poll question.
So we did prepare a poll to find out whether you are caring for someone who has incontinence issues, and I recognise that some people might be online because they're interested themselves, but it'd be interesting for us to know, yes, you are caring for someone who has incontinence issues, or maybe just the answer is no, I'm not, or maybe you're not even sure what incontinence is, or maybe your answer is no, you are just wanting to be prepared. But it's good for us to get an idea on who's online at the moment. So if you can answer, if one of those more closely suits you, or if you want to make a comment, you're welcome to do that as well. So there might be someone else who hasn't voted on that, maybe one more person who hasn't voted yet, and I'll share that with the group so you get an idea on who else is online as well. That's about everybody. So I'll close that and I'll share the results with you. So only 20% really are online because they're currently caring for someone who has continence issues, and a large section of the group are interested people.
Interested people? Yeah. Excellent.
Now again, fingers crossed that's come back to the slides for everyone at home as well.
So, shall I continue?
Yes,
excellent. Thank you. Thank you. So within the Continence Foundation of Australia website, there's a new web page, Caring for Someone with Incontinence, which you're welcome to follow the link and browse at your leisure. There were also 5 videos that were created, and the video topics were based on a survey of what carers wanted to know more about, and they included skincare, dementia, practical caring tips at home, products, and financial assistance. And you can have a look at the financial assistance video on the Caring for Someone with Incontinence website, and the other videos will come up as a rotation. Also, as part of World Continence Week, there was a review of some fact sheets and a booklet, and I have sent the booklet PDF and the 2 fact sheets as a handout for you to have a read through. So the booklet covers understanding incontinence, practical tips to manage incontinence, disability and incontinence, further advice and support. The Caring for Someone with Incontinence, it provides an overview of what incontinence risk, where to seek help, continence assessment, what you can do, financial assistance, and also some practical tips. And the Where to Get Help fact sheet looks at who to approach and what to ask, which is really important, asking the right questions, the different types of continence services, and also the different types of continence health professionals, for example, a continence nurse advisor, what their role is, a continence physiotherapist, and other medical specialists. There was also a double-sided poster that was created as part of World Continence Week. So if you are a health professional or anyone really can order the A3 size poster from our website, and that can be used ongoing as a promotional tool to encourage people to call the National Continence Helpline and seek help. We have a lot of resources. The ones I sent to you are just a sample of resources, so you're welcome to browse our resources. You can call our Continence Helpline, or you can visit continence.org.au and follow the resource link tab. So So that brings me to the end of my talk in regards to who we are and also the different resources that we offer for Well Continence Week. I will now pass you over to Lisa Ragg, who is a continence nurse consultant and also the Executive Officer of the Victorian Continence Resource Centre, and Lisa will be talking about support for continence management.
Sorry. We're being very technical. We're sharing the one camera. Oops. That's all right. Thanks, Lisa.
Ready to go?
Yeah.
As Amy said, this is our first time doing a webcam. It's quite weird. Hi, everyone. Apart from my role now with the Victorian Continence Foundation, I did work for the MS Society for 6 years as a continence nurse in Victoria from 1992 until 1998. So I got a really amazing insight into MS and the associated bladder and bowel problems that can come with this disease process. So, as you all know, MS is one of the most common non-traumatic nervous system disorders affecting young adults, usually between the ages of 20 years and 50 years of age. And approximately 90% of people suffering with MS will experience some bladder and bowel problems during the course of their disease process. But fatigue and bladder symptoms are often the first symptoms that people do experience. And from my experience, often people were having some bladder problems on and off before they even realised that they had a diagnosis of MS. So, MS causes damage to the myelin sheath, which is responsible for nerve conduction. And as you know, with the interruption of the conduction of nerve impulses along the nerve pathways, bladder dysfunction and also bowel dysfunction will occur. The level and type of dysfunction in MS will vary at different stages of the disease. One of the first introductions to working or meeting people who had MS, I met 3 people in the course of 1 week. They all had totally different presentations as far as their symptom picture went with MS, but they all had bladder problems. So one of the challenges for the clinician when looking at bladder and bowel issues with MS is also looking at the overall clinical picture of the other symptoms that an individual has and how you might then go on to help manage the problem. So, in order to successfully be continent, which means recognising that you have an urge to go to the toilet and then being able to hold on until you get there, it's a complex series of steps. And these are some of the steps which will often be reasons why incontinence starts to become a little bit problematic with MS. So you need to be able to recognise the need to go to the toilet. Then you need to be able to work out where you go to the toilet. You must be able to hold on or hang on until you get there and then get there in time. Once you're there, you need to be able to pass urine or faeces as soon as you're in position sitting on the toilet. And feel as though you've completely emptied your bladder and your bowel after you've finished. So this is a diagram of the nervous system which Micturition is a fancy word for emptying bladder or voiding. What I'm attempting to do here is to show you a picture of the bladder and as it relates to messages being sent to the spinal cord and on up to the brain, so that you can get a clearer understanding of how the lesions may impact on the messaging that is required for a smooth ability to get to the toilet. So the bladder, you've got the bladder, which has the outline of, well, the bladder wall is called the detrusor muscle, and the detrusor muscle sends messages to the spinal cord at the S2 to S4 area, and those messages are sent as the bladder starts to fill, and they get sent up the spinal cord to the pons switching center and onto your cerebral cortex to say that, hey, my bladder is starting to feel a little bit full. Is it possible to get to a toilet now? How urgent is this feeling? Can I hold on? Or do I really need to actually go right now? If the bladder is only full to about 200 or 300 mils, for most of us we're able to hold on, and so we send a message back from the brain down the spinal cord to the bladder that says, no, can't go yet, need to wait, and the bladder continues to fill. At a certain point, the pressure in the bladder becomes so high that the bladder will start to contract or squeeze, and it will want to empty. So the messages go back up to the brain via the spinal cord, and it's at that point that you really need to get going. And some of you may know the feeling of actually being in the car and you're okay coming home from the supermarket, and as soon as you get to the front door and you try to put the key in the lock, you can no longer hang on, and you might start to leak urine at that point. So the bladder, the urge to empty is so great that you're unable to stop that occurring. So it's a reflex arc which will continue. The bladder will continue to fill and empty regardless of whether you can consciously recognize the urge that you need to empty your bladder, or be able to physically stop the bladder from contracting. I hope that makes sense. So it is complex, and as you can see with MS, there's plenty of spots along the spinal cord and in the brain itself that could interrupt the pathways of the messaging. And this little picture is just a picture to actually reinforce what I've said, which is basically that the function of the bladder is to store and release urine. And you've also got your urethral sphincters, which are depicted as little brown bulges around the urethra where you've got the little red arrows. And they have a very high pressure, so they keep you from leaking while the bladder's filling. So the bladder fills and it's nice and relaxed as it fills, and the pressure in the bladder remains low. But then as the bladder fills to a certain extreme point, which is a different volume for each individual, that pressure overrides the pressure of your urethral sphincter, and then the bladder will squeeze, the sphincter will relax, and you'll empty your bladder completely, and then the cycle will start again. So with MS, when we talk about bladder sphincter dyssynergia, which will come up in a moment, what's happening is that a small degree of urine is being passed when the bladder's got a really high pressure in it and it forces the sphincter open. But then because there's a problem with the messaging and the nervous system, the sphincter might jam shut as soon as the pressure in the bladder has lowered a tiny bit, and the sphincter itself has a high pressure again, and so it shuts. So then you get you'll have one drink of water, your bladder pressure will increase again, it's higher than the pressure of the sphincter, so it contracts again to empty a little bit, and then it shuts again. So you can get this situation of frequency where you're going to the toilet a lot, but you're not actually emptying your bladder completely because the messaging isn't working properly due to the MS. Are there any questions at the moment?
Not so far, but I would encourage everybody to type them in even as you start thinking about the questions, because of that, you know, the idea of the time it takes to type. Find that question section in the control panel and hop into questions.
Okay, so with MS, with easy language, there tends to be 3 different kinds of bladder dysfunction, and you can also get a mixture of all of them during your during the disease process of MS. So you can have failure to store, which means the bladder can't fill up completely, or you can have failure to empty, which means the bladder doesn't empty properly, or you can have a combination of the two, which is what I was just talking about. So with failure to store, it does set up a urine urgency and urge incontinence. So the bladder is filling, but it's got this overwhelming desire to squeeze and squeeze really hard, and therefore in that process it's often difficult for people to exert enough pressure on their pelvic floor to stop them from losing urine. So when the bladder squeezes really hard, even when it's not completely full, the muscles that hold the bladder closed may not be strong enough to resist the squeeze, so that you need to rush to the toilet even though you went recently. So the urge incontinence is sudden and it's strong, and it's very hard to stop. You usually can't get to the toilet on time. You may lose a full bladder load, or you may lose a considerable volume of urine during urine urgency and urge incontinence. And the triggers are often running water. They're often the key in the lock syndrome that I was saying before. And as time goes by, the bladder becomes less elastic, and so it can hold less urine because it can't stretch as well. And so you get a situation where you're still getting an overwhelming desire to pass urine, even though it's not a really large volume in the bladder. So with urine retention or overflow incontinence, which is failure to empty, some of the bladder symptoms that you may experience are frequency, hesitancy, recurrent urine infections, nocturia, which means waking up overnight more than twice to go to the toilet, dribbling after you've passed urine, a sense of the bladder not being emptied completely, or incontinence. And the tap is a good analogy to what's actually happening with the bladder. So the sink is overflowing. So it's holding as much water as it possibly can, and it's the overflow that is going onto the floor with retention or failure to empty. What you're seeing is the drips that are being passed as you would think you're emptying your bladder is just the overflow. So the bladder itself is not emptying completely. And I suppose one of the biggest problems with this is that for people with MS, if you are getting recurrent urinary tract infections, that can elevate your temperature, your body temperature, and for some people it can also exacerbate their symptom picture of MS until the urinary tract infection settles down. So people will feel like they need to strain when they're passing urine and may sit on the toilet for a long period of time, but also become very tired because they're actually going to the toilet 24/7. Some clients that I was seeing at the time would be going to the toilet 25 times a day, which is pretty exhausting. And it starts to have an impact on your sleep pattern as well as your ability to work. So this diagram of bladder sphincter dyssynergia is really just showing what happens more with an underactive bladder, but bladder sphincter dyssynergia, what you would often see if you do urodynamics or video urodynamics is that instead of the bladder looking nice and round, it ends up looking like a piece of ginger. And what happens when you've got that situation is that there's little areas of the bladder that can have urine pooling in the little, like just little pockets, and that gets infected, and it can get really seriously infected because it will never empty properly. So when we talk about bladder sphincter dyssynergia, it's quite a complex problem that's occurring, and it is occurring because of the affected messaging that's going on from the bladder up to the brain and back down again. But essentially what's happening is that you get all of the symptoms that you can possibly think of. So frequency, hesitancy, urine urgency, urge incontinence, urinary tract infections, incomplete emptying, nocturia, dribbling, and if the detrusor is underactive over time, as I said before, the bladder just becomes floppy and it gets out of shape, or it becomes a very small bladder that can't hold a large volume, but it's still very twitchy and hyperactive. So, continence management plans for MS, for people with MS, to really look at what is going on as far as the bladder problems go, but also what's going on as far as your symptom picture goes with your MS. So they're person-centered plans. They have to be focused around what the individual can and can't do as far as the management plan goes. They need to be adhered to, and there needs to be follow-up and monitoring because of the unpredictability of MS. So the other things that need to be taken into account are the kind of mobility impairment, dexterity impairment, cognitive impairment, and the bladder and bowel impairments that may also be going on at the same time as to how you manage the various different kinds of bladder problems. So there are lots of pharmacological treatments out there on the market. Most of you, if you have had some bladder problems, would have heard of them. Oxybutynin has been around for the longest. Usually an individual will be put on the tablets as a starting point, and if the tablets are causing too many side effects, particularly a dry mouth or constipation, then they'll be put onto the patches, which often have a better effect because of the way that the medication itself is absorbed. You need to go through the oxybutynin before you can go on to Vesicare in most situations. The Vesicare is a much better medication for overactive bladders in the sense that there seem to be less side effects of the dry mouth, of the constipation. However, Vesicare costs you about $50 a month. But if it's doing the job and you don't need to buy continence pads or other devices, then it might be a better way to spend CAPS funding. Enable-X is also a medication similar to Vesicare, as is mirabegron tablets. They're all designed to actually reduce the hyperactivity of the bladder, so to make the bladder less active when it's filling up with urine, so that it gives you a bit more time to get to the toilet, and it gives you gives the bladder more opportunity to fill up to a greater volume before you need to go to the toilet. You usually need to go through all these medication or a variety of these medication before you'll be considered for Botox into the bladder. Botox has just been put onto the PBS scheme, and Botox injections are free for 2 injections over a 12-month period, I think. And the Botox is injected into various parts of the bladder wall, and the idea is that it stops the hyperactivity of the bladder wall. So it stops the bladder from contracting and gives you, again, more time to get to the toilet, the bladder more opportunity to fill up completely. And for some people, the Botox injections will actually put you into retention, and then you will self-catheterize to empty your bladder. So the idea behind it is that it makes life more manageable and keeps you out of the toilet. So hopefully it would put you into a more normal way of voiding that you would have experienced pre-MS. Any questions?
No, not so far.
Okay. Anyone still there?
Hoping so. I would just say that the people that might have joined us more recently, if you're not sure where to type in your questions, you're looking to maximise your control panel on the right-hand side of your screen, or if you're on a tablet or a tablet kind of device, you're looking for the grey question mark where to type in questions or comments.
Okay, so there are also some pharmacological treatments to improve urine flow. From my experience, they don't tend to be that successful when they're being used for an MS bladder to reduce the pressure in the urethra, which is really what they're trying to do, so that when the bladder contracts, they're acting on the urethral sphincter to try and keep that pressure low so that the bladder can empty completely. Flomax is more often used for people who have a problem with bladder emptying related to a prostate problem, which is probably a good thing to remind you all of as well, that just because you have MS, it doesn't necessarily mean that bladder problems are going to be related to MS. They may also be related to stress incontinence from childbirth, or because of an enlarged prostate that is starting to become a bit problematic. So you do really need to get it checked out to make sure that it is what it is, and don't just accept that it's because you have MS.
There have been, someone's asking for clarification with the previous slide, why there's the need to go through one medication before you can get the next medication.
Look, that's a good question. I think it was because they wanted to make sure, originally oxybutynin was really the only medication that was out there that had been deemed effective. And as time went by, they were able to take it from a tablet form to a patch form, and it was on the PBS list. So it was the only medication of its kind that was free, and then further medications were considered stronger, and so therefore they wanted to make sure that if you were having some improvement with the ditropan, but it could be improved to a greater extent, or there really wasn't any improvement at all, but you've given it a try, then it was reasonable to actually give the Vesicare a try. I think that's the only reason, but the Vesicare has to, not being on the PBS, needs to get a different script from the doctors. And I think that's really the main reason. The Enable-X, those tablets have since come on, and I think, you know, from a timing point of view, they're on the market at the same time Botox is on the market, and Botox is definitely probably would be the treatment of choice. So they try and get you to give the different medication a go before you go for the Botox. I think that's really all it is.
Yeah, absolutely. And someone who has noticed that they've started having to get up 3 or 4 times a night, will that just stop, or what should they do?
No, it won't just stop. It needs to be, you need to have the situation assessed. It might be that you have a urine infection. It might be that you're constipated, and if that is the case, then if the constipation's treated and if the urine infection is treated, then waking up overnight might stop. So it's worthwhile getting it checked out, because it won't stop on its own.
They have had it checked since the virus. It's not normal to have to get up 3 or 4 times a night.
No, and I think ask yourself in that time when you're waking up, do you feel as though you're emptying your bladder completely, or do you feel as though you could empty further? One of the tricks to try and do is to sit on the toilet after you've initially emptied your bladder, and then just put your hand over your suprapubic area, so your thumb sits just below your belly button, and then you just gently tap your bladder and rock a little bit, and that might increase an additional amount of urine being passed.
Even standing up and sitting down again?
Probably more just a rocking,
okay.
Yeah, a rocking on the toilet. But gentle. You don't bash your bladder, and you don't rock so that you're going to fall off the toilet. And if that does stimulate an additional flow of urine, then it probably does suggest that you're not emptying your bladder properly, and it is worthwhile going and getting an assessment.
And then there's another question, but I think you will address this shortly, but keep it in mind. Instead of medication, can other products be used?
Yes, yes, absolutely. I always put the medication up because most people want the medication first. But yeah, there's multiple ways of managing the bladder issues, and I'll go through them in a moment. Oh, here we are. Okay.
Great segue.
Yeah. All right. So depending on the situation, there are lots of products available. I have bought some today just to show, but there's little pads that most people will be aware of that you can purchase at the supermarkets, particularly. The Tenor products and the Depend products are easily recognisable and well advertised, and they are for small volume loss of urine. A lot of women will go for the feminine hygiene pads. The problem with those is that even though they're small and discreet, they're not designed to absorb urine, so they don't work. And what you may find is that you feel wetter than if you actually had a small continence pad in place. And you may also find that you start to get a bit of skin breakdown if you're using the feminine hygiene pads. So I would say that if it's only a small volume of urine loss that you're experiencing, just discreetly put one of those small volume pad packets into your shopping and just start using them. There's also washable protective underwear, of which I do have a few kinds for women, and they're quite pretty. You can get these pretty little ones that have got a little built-in pad that don't cost a lot of money, and they're washable and reusable. And for some people, they're more acceptable than wearing pads. For men, the same deal. You can get the male products with built-in pads, and they can come in boxer short style or the normal jock style, but they all hold around 200 mils of urine. That's the maximum volume that they'll hold. There's leak-proof swimwear, so for people who are wanting to go to the swimming pool but they're having problems with their bowels, these swimwear are designed to actually completely contain a bowel action, and they go in sizes up to size 16. For urinals and portable drainage devices, there's female and male products. So this is a little male product that is called a Uri bag, and obviously you just pour it into here and it holds a litre. They also have them with a female lip like this one, which is called a wee john, and they have crystals in them which actually cause the urine to turn to a gel, so you don't leak it afterwards. And then for the blokes, you can get little stick-on pads that are specifically male or orientated.
Just back a bit closer to you.
Okay, can you see like that? So for a man, they can pop the penis and the scrotum into this pad, and the sticky bit will stick on the back of the undies. There's also condom drainage. This is an example of a measure. The penis gets put into one of these areas, and you get an idea of roughly what size they'll be. Men always put themselves up a size higher. And these are an example of the kinds of condom packaging that you can get. So again, very discreet, and they open and the little condom pops up and it just gets placed onto the tip of the penis, and then you just pull it on like that, and then it sticks, and they're good for 24 hours.
Lisa, would people just get these from the chemist, or are they better to get advice?
So these things, you can sometimes buy them from the chemist, but these are things that you can get on subsidy schemes. So in New South Wales, it's a different subsidy scheme to Melbourne. They're all state-by-state subsidy schemes, and I think the New South Wales is called Enable, I think.
It is.
Yeah. You can also go to the National Continence Foundation website, and there is a brochure there that you can download that gives you the name of the various schemes in each territory, and each scheme will give you an amount of money that you can use over the course of a year, but you do need a continence nurse to actually write those prescriptions. So things like condom drainage are worth about $2.50 each. So over a 6-month period, it does start to get expensive. But if you can, down in Melbourne, we call it the statewide equipment program, and they'll provide up to $1,200 worth of condom drainage for a year. So it'll be a similar scenario with Enable-X. You can also get your urinals, your washable bottles, your catheters. Those sorts of things will be on your statewide equipment programs. The disposable stuff varies, but around Australia everyone can go onto the Continence AIDS payment scheme, which is only a small amount of money, I know, but it still helps paying for the pads. So I just also wanted to just show you the difference in size for catheters. An in and out catheter for a male is much longer than an in and out catheter for a female, and for many people with MS, they often do learn how to self-catheterize, and those catheters they get on subsidy schemes. There are clamps for males as well, but I didn't bring any today. So clean intermittent catheterization, this is just a picture of a female where the catheter actually is inserted. So you can see that where the red arrows are, the little catheter is being inserted through the urethra up into the bladder, and the urethra sits in front of the vaginal canal, and the vaginal canal sits in front of the anus. So we teach people how to learn to self-catheterize if they're having problems with bladder emptying or dyssynergia. For women, it's a bit more tricky because you can't actually see your urethra, so it's very important how to learn to self-catheterize. There's also lots of equipment to help in terms of little mirrors that can be taped onto your leg so that you can visualize your urethra. And if you've got problems with dexterity or fine motor skills, there's lots of devices in catheters these days, like this one, for example, that's got a thickened component to it so that you don't have to clench so finely to put the catheter in. For men, it's obvious with catheterisation, intermittent catheterisation, where they need to go. The trick for them is that they have a much longer urethra that's got an S shape, so we just need to show them how to get through the S-bend successfully. Catheterisation, while it's like, oh my God, really, is actually the best way to manage the bladder, because if you're doing it successfully, you'll be able to empty your bladder completely up to 4, 5, maybe 6 times a day, and you should be able to sleep through the night and continue to live a normal life without having to worry about where the toilets are on wherever you go. So I just mention a little bit about some of the problems that people may experience with MS and sexual function. They are also quite common, and I'm sure the MS Society, in fact I know the MS Society does have information around sexual function and ways to move forward in relationships. But sometimes people do experience pain, which is new or different to the pain they may have had in the past. It's a pain associated with nerves not working properly, and for men sometimes they can stay erect for a longer period of time than they would normally, and it's painful. For women as well, they can experience an oval or hyper sensation after orgasm or prior to orgasm that's painful. Erectile dysfunction is often the case for men, that they can't actually, they lose their ability to become erect. Incontinence can also be something that impacts on an individual's desire to want to have sex, and so then that can then impact on the relationship. So they are very real things that people experience with MS, and there is resources available, and there's also various medication and injections that might work for men. So if it's something that is becoming a problem, I really do ask you to go and seek some advice from your health professional. So, stools and bowel health. So the perfect stool should be soft but firm, easy to pass, light to dark brown, banana shaped with minimal odour. That is the perfect stool, and for a lot of people with MS that's really hard to achieve. It is for others as well. Excuse me. So if you've got pale or clay coloured stools, then there may be some liver or gallbladder problems. If your stools are really pencil or ribbon thin, then you may have some problems with bowel just not moving as effectively. Palates or constipation, palates or frothy or unformed diarrhea needs attention. Really foul smelling stools, it might be that there's a bacterial infection in the gut. You certainly need to go to a dietitian and have your diet looked at. And if your stools are floating and they don't actually flush very well, then there may be some fat or nutrient malabsorption, which needs to be checked out as well. Excuse me. So the Bristol Stool Scale, I'd love to see a poll on how many people know about the Bristol stool chart, but it is a fantastic chart, and the normal range of bowel actions is 3 times a day to 3 times a week. For someone with MS, that can vary quite dramatically. I had one lady at one time who used to have a bowel action once every 7 days, and when she had that bowel action, she actually obstructed the toilet. Took us a long time to get her into a routine, but when we did get her into a routine, she thought something was really wrong because she hadn't experienced a regular bowel action for many, many years. So it is really important with MS to try and get a really regular bowel action, because it will actually make a difference on how your bladder's functioning. So normal bowel function, what we mean is that you've got the ability to hold on after you get the first urge that you need to open your bowels, that once you get to the toilet and seated on the toilet, that you can commence the bowel action straight away, and that you feel completely empty after you've had a bowel action. So bowel problems associated with MS, which may mean that what I've just said isn't what you experience, could be due to reduced peristalsis. And what we mean by peristalsis is it's this movement that pushes feces along the large bowel. And with MS, like every other function in the body, peristalsis comes about because of nerve control, and so that can be affected, and you find it more difficult to actually push. Feces doesn't get moved along the bowel as efficiently. And on top of that, depending on where you are with your MS, there's often reduced mobility as well. So you're not moving around as fast as you were before or as often as you were before. So your whole system tends to slow down. There's also lack of coordination of the anal sphincters. So when I was talking about the bladder before not being able to empty completely, you can have the same problem with the bowel. So there's 2 kinds of sphincters. There's the internal anal sphincter and the external anal sphincter, and they need to be coordinated and relaxed at the same time for a bowel action to occur, and sometimes they're not. So it pushes the feces or the stool back up into the rectum, and every time a bowel action or the stool is pushed back up into the rectum, it dries out more. So over time, you get a really hard mass of stool sitting in your rectum. There's also reduced anal sensation, which can make it very difficult to know when you need to go to the toilet. So for some people, they feel as though they need to open their bowels, but when they're at the toilet, they can't open their bowels, and at other times they can't feel that they've had a bowel action, which is very distressing. And therefore the complete evacuation of stool, again because of nervous control. So this picture is just a picture to show you what's happening at the rectum and anal interface, the anal canal. You've got the IAS, which is your internal anal sphincter, and that controls liquid and gas from leaking out into the anal canal. And the EAS is your external anal sphincter, which is the one that you tighten when you're wanting to hold in wind or when you need to go, when you're trying to do your pelvic floor exercises. So the external anal sphincter is under voluntary control. So it's the one that you can tighten and release and use to hold on with, whereas your internal anal sphincter is not. So it's actually on an automatic mechanism. So just put this picture in to actually show you what we would see on an X-ray for someone who's really constipated.
You can use the arrow.
Oh, good.
I think that shows up for people at home.
Okay, so this is the right side of the X-ray, and this is the left. So the black here is wind. So that's gas that you can see, which is in the ascending part of the large bowel. So this is the large bowel, and this is the ascending part of the large bowel, and then it comes up to about here, just around, this is called the hepatic flexure, where you've got your liver just around here somewhere, and it turns into the transverse colon, which is large bowel, and it's transverse, so it goes right across to the left-hand side, and all this white stuff is poo, and it's everywhere. So it's filling up the entire large bowel, and then this really white area here is what you call the splenic flexure, that's near the spleen, and then you start to come down, and you can see all this area here is poo, and that's your descending colon. So it comes down here, right here, this is the sigmoid colon here, into the rectum. So the rectum is your holding bay. Before you actually pass a bowel action, it sits in the rectum, and then it goes through the anal canal and you pass. So you can see how enlarged this rectum is, because it's got a huge amount of stool in it, and that would be the size of a cow patty when you passed it. And you can see how uncomfortable a person must feel when they're this full of feces. They're really blocked, they're really uncomfortable, and the bladder sits around here somewhere as well. So the huge pressure of all of this feces puts onto the bladder. It makes it difficult for the bladder to enlarge, so the bladder can't fill up properly either. And so for that person earlier, if they are constipated and they're starting to go to the toilet a lot at night, it might be that the bladder just can't fill up properly because you're constipated, but it might be also because you're not emptying properly. So when we look at how to manage people with really severe constipation, sometimes they need something to help peristalsis, which is to help push the feces or poo along through the large bowel, and sometimes they need suppositories or enemas to actually help get rid of it out of the rectum, because they've forgotten, or it's not that you've forgotten, it's just that your sensation is reduced, and that incoordination is occurring and you just can't empty properly. So to unblock someone like this, you're looking at probably a really solid 3-month process. And then after that, you would be putting people onto a routine bowel aperient, because you just don't want this. one lady that we cleared, she lost 3 kilos. So it's how much the bowel can hold when you're really full. So signs and symptoms of severe constipation would be that you're actually losing your appetite, you're starting to feel a bit nauseated, you're really straining to open your bowels. You may also have explosive diarrhea, because what can get past these blockages is fluid, so it's just going to seep out wherever it can and just forcefully push its way out. Or you can start to get fecal breath, so your breath actually starts to smell like feces. So you really do need to address the bowel issue. Any questions? Okay, so the diet and fluids is something that you probably all know about, and it's something that we always bang on about. And obviously there's lots of different kinds of fluids that you can drink, but the caffeine or the caffeinated fluids for some people just don't work very well with their bladder, because they just add to the bladder being more twitchy, and therefore it's harder to hold on to urine when you've got a full bladder. The alcohol works differently. What it does is that, you know, when you go out and have a night out and you can drink and drink and drink, and then all of a sudden you just need to start going to the loo, and you go to the loo over and over and over again. What happens is that the alcohol, after a while, it turns off a hormone in our system which is called antidiuretic hormone, and that hormone is responsible for reducing the amount of urine that we make. So when you've got a lot of alcohol on board, it turns that hormone off, so you make more urine and you need to go to the toilet more often. So water is the best. However, there's lots of herbal fluids. There's heaps of choices out there. And for a lot of you, you will be looking at diets and fluid intake on the web, see what's new and what might work. So keep your caffeinated fluids to a workable level. I don't say give it up completely, but pick the ones that you like the most and get rid of the others. And the diet, the dietary fibre intake is a tricky one, because different people need different kinds of fibre. So not always wheat-based, fibre is not always the best. So it's a bit of trial and error there, but I tend to err more on the side of your soluble fibres. So your porridge, your oat bran, things like that are just a bit softer on bowel, and they don't need as much water to get them through the system. So yeah, your gel-soluble fibres are fermentable and they're prebiotic, and they put good bacteria into the bowel, and the bacteria in the bowel are really important for reducing the amount of wind that you make, and also it stops the stools being so foul-smelling. So they do add bulk to the stool, but the soluble fibre turns into a gel during digestion, so it can firm up and slow down emotions for people who are suffering with diarrhea. But also it helps for people who aren't moving as well. It just absorbs more and more fluid the longer it sits there, and that's wheat-based. So that's your stringy insoluble fibres, where they will increase your stool weight and they do hold water. So they will speed up bowel motions, and they are useful for treating constipation, but it really depends on a few other factors as to what might be the best fibre for you.
So what falls into that category?
I think I've got a list.
Ah.
Yes, I thought that might be handy for all of you out there. What are gel-soluble fibres and what are insoluble fibres? So you could maybe start to incorporate some of them into your diet if you're actually finding that constipation is becoming a bit of a problem. So, for example, you could put your chia seeds or your linseeds onto your oatmeal for breakfast. You put some oat bran in yogurt, or you could make a smoothie with all of the above in it, the psyllium or the slippery elm. The lentils you could incorporate into some of your meat meals, or you could just have a few nights where you don't eat meat at all and you just stick with your pulses. Yeah, there's a lot more foods out there, but this is a fairly good starting point for you. So if you're not mad keen on water, maybe you could make yourself a pumpkin soup or a carrot, you know, a minestrone. You know, there's a fair bit that you can choose from in this list that might be, you know, good options. Versus your more insoluble fibres, which if you have really slowed down with your mobility, I'd be steering away from. Obviously tomatoes, they do also have a lot of water in them, so they're probably not such a big deal. But your mueslis and your whole grains, your wheat bran, your rice bran, they do absorb a lot of water. So this is a correct toileting position, and what we're trying to do there is to actually get you into a squat position but sitting on a toilet. And the reason for that is that it will help reduce the angle, the anorectal angle when you're passing a bowel action, and a really good time to sit on the toilet is after you've had a meal, because it takes advantage of the gastrocolic reflex, and the gastrocolic reflex always happens after you eat. So it naturally tries to encourage the bowel or the rectum to empty because it's full for the next load of food coming down, going into the waiting bay, so to speak. So if you can get yourself into that kind of position, that is the best position. And for some of you, you may actually need to have a grab rail nearby so that you can, you know, hold on and be stable in a position like that. So this is just reinforcing how aperients work at relieving constipation. So you've got your stimulants, and an example of a stimulant would be Senecot. They increase that peristalsis, but they're pretty brutal, and they can also, if you take too much of it, end up with that crampy diarrhea feeling. You'll also get that from your Herbalax and Nutrilax mixtures, which are like a big date sort of mixture, and a lot of people eat a bit too much of that. Your bulking agents will just increase the bulk of the stool, and we've just talked about those. The osmotic agents, what they do is they draw fluid into the stool, and things like that are the Osmolax and the Movicol, and by bringing water into the stool, they help it move along the bowel. The stool softeners are like your Caloxyl. Caloxyl and Senna is really common. The reason what that does is just try and soften a really hard stool and help it move along. The lubricants put like your psyllium husks or your slippery elm. put a mucilaginous like gel around the outside of the stool and help it slide down. And then of course you've got your suppositories and enemas, which just irritate the rectum locally. So just the other things to be aware of with MS and toileting, particularly if you are actually learning how to self-catheterize, or you need to be in a better position when you're actually sitting on the toilet, is adequate lighting, cooling. I put heating in brackets because most people with MS get overheated more quickly than the rest of us, and so they tend to need to have a cool environment. Handrails, a space for wheelchair transfers. You might be a stand transfer. You might have a little disc that you stand on that transfers you onto the toilet. You might need to have either a shower or commode that you are put onto before you get into the toilet. You may need a hoist that might be mobile, or it might have tracking in the bathroom or toilet that you are attached to get down into the toilet. And you might need a footstool to actually be well balanced and braced in the best position for toileting. Adapted clothing might be something that you also need to consider, and there are pieces of equipment that can help if your dexterity or fine hand movement's been affected. So dressing sticks with rubber tips, where one end, rubber tip on one end and a hook on the other, or pants clips, where you've got a piece of elastic with a clip at either end, so click onto your pants and your shirts. French style knickers, so they're sort of a bit more open, so if you haven't got time to pull them down, you can just pull them aside. Drop front or side opening undies, and incontinence swimwear, which I showed you before. And then out and about, there's a National Public Toilet Map app, which you can download for free through the National Continence website, National Continence Foundation website. Chair pads, which are like this material that you can put in the car or you can take with you wherever you're going. This is obviously a sample, it's not that chair pad, but they hold about 1 litre of fluid. Take an accident pack with you, or you can take some of the little portable travel johns that I showed earlier, like this or the other one. You can also buy the crystals that turn water into a gel from the plant nurseries. So if you've got a normal urinal that you're using or a bucket or something, you can put the crystals in that and your urine will turn to a gel, so it prevents spillage.
It's also the MLAC key. We have a handout about that, so the master locksmith key
Yes.
to lock toilets.
Yes.
So if people need that, we can send that to them.
Excellent. Excellent. And then the other thing is that some people may need a bit of prompted toileting if the memory is starting to be a bit of a problem. And that might be either verbal prompts or it might be a visual prompt. It might be a wristwatch or your phone. You can just set an alarm to remind you to go to the toilet at specific times, or they might be written prompts, all about just reminding you to go to the toilet, or when you're in the loo, what to do next. And the financial support for continence aids exists. NDIS into the future will be dependent on whether or not you're eligible in their level of impairment. However, if you are and you're on that scheme, then you will be able to get whatever continence products you need without there being a ceiling on the cost that you can have. And as I said earlier, it varies from state to state. The Continence Aid payment scheme is up to about $650 a year, I think, roughly. If you are a veteran gold card, you can get product through them. And I know there's other state schemes that I haven't got listed here, but go to the website.
Lisa, a question came in earlier. Can you get the state funding, so SWEP or Enable funding, as well as the CAPS funding?
Yes, yes, absolutely. So the best way to do that is to get the things that are reusable or not funded on CAPS through the statewide equipment program, so that you've got all your CAPS funding for your disposable pads.
And for either of those, do you need a continence nurse to make that?
You can use either a continence nurse. Well, you need a continence nurse for statewide equipment program to write the scripts for continence aids. As far as the CAP schemes go, you can use physio, OT, your local doctor or a Division 1 nurse. As long as you know what you want as far as product goes. The advantage of a continence nurse is that they are all across all of the product and can organise samples for you. But if you're happy with what you've got, or you've got an outlet that you can ring like Independence Australia and get samples, then anyone can fill out the form in those categories. Any other questions?
People will type them in, I'm sure, as we're going. Someone asked the question about how do they get the handouts. You should be able to see the handouts as part of your control panel on your screen, and in a perfect world you would double click on them and download them onto your computer, and then you can print them or refer to them later. If you have trouble with that, by all means email me and I'll attach them to an email and send them back to you. But if you've got questions, are we up to question time, Lisa? Yep. Pearl's asking how we get the MLAC key. I can send out, and maybe I'll just send it out to everybody, the little handout we've got about the special, it's not a special key, it's a universal key to all the public toilets. So if they're locked, you can get into them. I'll send that out to everybody.
I would like to make it really clear though, with bladder problems and MS, they can change from time to time. So you might start off with a bladder that isn't emptying properly, but you might find that moves to a bladder that empties completely. It does vary according to where your lesions are and the degree of interference in the nerve pathways. So I really do strongly suggest that you make friends with a continence nurse and you do get followed up regularly, just to make sure that there isn't any change and that what you're doing is the best thing for you at the moment. It's really sad when people feel like they just don't want to deal with the bladder or bowel problem, and that then starts to impact on the rest of their lifestyle with MS. It really is a wellness model, as you know, and the bladder and bowel are part of the process. But once you get them sorted out, you should be all right for a while, and hopefully it will stay pretty stable and there won't be too many changes. But if you have an exacerbation and you've been doing self-catheterisation and all of a sudden your vision's not as good anymore, or you find hand movements not as good anymore, or your balance has changed, then that might affect your ability to do self-catheterisation the way that you've been doing it. But that doesn't mean that you still can't do it, because we've got lots of different little devices that we can introduce to keep you going, doing what you're most familiar with for as long as possible. So I just really want to stress that. And the bowels, just get them into a routine as soon as you can, and once they're in a routine and they're responding well to an aperient, don't stop the aperient. Keep it going.
We often find people hesitant to speak up about issues because they think it's just them.
No.
You know, that's how I am, and I just have to put up with it. But we would always say, ask.
Definitely ask, and you're not alone, and continence nurses really can make a difference. And if it's not a continence nurse, a continence service will really be able to, just to help you out and make a difference. And some of you may already have a urologist involved, and it may be the urologist who's your port of call and the urology nurse. Just as long as you've got somebody involved, rather than trying to pretend it doesn't exist.
And if you're caring for someone who has some issues, then again, maybe encouraging them to go to the doctor, maybe go with them and have that conversation.
Yeah, and look, you know, there's been many a carer that we have taught how to self-catheterise their loved one. It does change the relationship, I recognise that. But by the same token, if it means that they can have an in and out catheter rather than a permanent catheter, then that's usually a much preferred outcome.
Someone else has said they had trouble with the handout, so I'll just routinely, send everyone the handouts as well. A copy of the toilet positioning picture was one of the slides in the handout, so you'd be able to see that in that. So I would say we might be heading towards the end of our questions, but as with all our webinars, if you've got other questions that have come up because of listening to today's talk, by all means get in touch with the 1-800 number that Lisa and Amy presented at the start, or get in touch with MS Connect. Any questions you have, it would be great to follow them up. Don't just think that, you know, it's general advice. You need some specific advice sometimes, and it's good to make a call. Thank you very much, Amy and Lisa. There seem to be some thanks coming in, but no other questions at the moment. So I think we're right to say good afternoon to everybody.
Can I just say one thing? We've put together a short survey that Andrea will send out to you. If you could please fill it out and send it back, we would really appreciate your feedback. Thank you.
That's an online survey, and you'll all get that tomorrow in an email, and we would encourage you to click that link.
Thank you.
Okay. Thanks. Everybody.